Spirometry is a fifth vital sign, non-invasive method of measuring hemoglobin saturation by using a light signal transmitted through tissue. Pulse oximeter estimates SpO2 from differential absorption of red and infrared light in the blood. Reduced HP absorbs more light than oxyhemoglobin in the red blood, whereas oxyhemoglobin absorbs more light in the infrared band. Pulse oximeter discriminates between arterial blood and other components by determining the change in transmitted light caused by arterial blood flow. It pulses red and infrared LEDs on and off several hundred times per second. The rapid sampling rate allows the peak and trough of each pulse wave to be recognized. At the trough, the light transmitted through a vascular bed that contains mainly capillary and venous blood. At the peak, it shines through all this plus arterial blood. A photodiode collects the transmitted light and converts it into electrical signals. The emitted signals are amplified and processed. Transmission pulse oximetry. It's the most common type. Light is transmitted through vascular bed and detected on the opposite side of the bed. Reflectance pulse oximetry. It relies on light that is reflected to determine oxygen saturation. The probe has both an LED and photodetector on same side. Pierce law. It is the intensity of transmitted light decreases as the concentration of the substance increases. Lambert's law. It is the intensity of transmitted light decreases exponentially as the distance traveled through the substance increases. The equipments are probe, cable, console, where signals processed and values are reported. Sites. Finger is the most commonly placed. Uh, it is most commonly placed over one of the finger. Location offers low failure rate. Vigorously rubbing the fingertip may temporarily improve the circulation in the area. The pulse oximeter will not generate an alarm during inflation cycle if placed on the same arm as the blood pressure cuff. Occasionally, poor function may occur with probe attachment on the same extremity as the IV infusion because of local hypothermia and vasoconstriction. The other sites are nose, toe, ear, tongue, cheek, forehead, and esophagus. Uh, Monitoring oxygenation. Oxygen desaturation can occur anytime during anesthesia. Pediatric patients are especially at risk. Studies have shown that incidence of hypoxemic events and myocardial ischemia is reduced when pulse oximetry is used. It is useful in managing one lung anesthesia to help to determine whether measures taken to increase oxygen saturation are necessary or effective. It is useful to confirm correct tracheal tube placement when a function CO2 monitor is not available. If oxygen saturation rises after intubation and ventilation, correct tube placement is likely. Advantages are it is accurate, non-invasive, perfusion indicated by pulse signal strength, oxygenation indicated by saturation, easy and fast. Its disadvantages are it is inaccurate in bilirubinemia, low saturation, malposition probe, venous pulsation, mixing probe, severe anemia, skin pigmentation, dyes, nail polish and coverings, pressure on probe, hyperemia, probe discharge. Next is capnography. It has mainstream analysis and side stream analysis. In mainstream analysis, sampling window inside the ventilator circuit. In side stream, it is away from the ventilator circuit. All CO2 monitors today include a waveform. It can be either displayed on an oscilloscope or printed on a paper. It has totally four phases. The phase 1 begins at E. Since the inspired gas does not contain CO2, in phase 2, the rapid S-shaped upswing represents the transition from dead space gas that does not participate in gas exchange to alveolar gas that contains CO2. In phase 3, as gas coming almost entirely from alveoli is exhaled, plateau is normally seen. If plateau is not present, correlation between arterial and end-tidal CO2 gradient is not likely to be good. In phase 3, slope is increased by ventilation perfusion abnormalities in lung or kinked tracheal tube. The last portion of phase 3 identified by D is referred as end-tidal point. In normal individual, it is 35 to 40 thar. Angle between phase 2 and phase 3 is alpha. Normally, it is 100 to 110 degree. It is decreased in obstructive lung diseases. Angle between phase 3 and descending lip of capnogram is beta angle. Its normal value is approximately 90 degree. In phase 4, the patient inhales CO2 falls abruptly to 0 and remains at 0 until the next exhalation. The low end tidal is CO2 is seen in hyperventilation, increase in dead space ventilation. The elevated end tidal CO2 is it occurs in CO2 production increase that is most common in malignant hypothermia or with hypoventilation or CO2 being observed during laparoscopy, tourniquet release, increased muscle tone, shivering and convulsion. Uh, Curare cleft seen during spontaneous ventilation. The depth of the cleft is proportional to degree of remaining muscle paralysis. The next one is transcutaneous monitoring. It measures O2 and CO2 diffusing through skin, mainly used in infants in NICU and PSU. Relies on oxygen content on capillary blood. It measures by heating skin locally to dilate capillaries. The heat emitted by the electrode may cause areas of redness on the skin, hence the site of placement of the sensor need to be changed regularly. Thank you.
Completed?
Yes.
Okay. So this again, you are just mentioning only about pulse oximetry and capnography as the two main monitors for respiratory system function.
Yes.
As all of you know that the main function of respiratory system is to deliver oxygen to the tissues for their metabolism and remove the carbon dioxide which is produced because of aerobic metabolism through the lungs. This is the basic function of our respiratory system. And those two functions you have monitored. But apart from that, what about ABG? What about apnea monitoring? These are also because under when you use these are used during anesthesia, not in a normal ambulance patient. When they come for anesthesia and surgery, these monitors become very important.
Yes.
Apart from that, in major cases, when there are likely fluctuations in these values, you must also have a system to monitor the arterial blood gases, which are the main transport mechanisms for this oxygen and carbon dioxide.
Yes.
And other, if the patient stops breathing, there must be a way to identify that also. So these four questions actually I have asked in today's class are all taken from Miller only, which I consider are very gray areas which are suddenly asked in the examination, which many times students find it difficult to answer. So that is the reason why I went through all those chapters and then made a presentation also and try to simplify it as much as possible for you to have an idea so that you can add your own knowledge and then make a decent answer for that. So I'll just show the presentation.
Sure.